when we first started out, and I think we were, I guess, using it more as a rescue therapy in the early patients. And has the trend evolved and from rescue to monotherapy? And how fascinating is that?
Yeah, listen, I think that's a really, really astute observation. Listen, when Hemospray first came on the shelf, it was like the Wild West in my endoscopy unit because, as soon as there was a molecule of red blood cell circulating, everyone would reach for it. I think the most important thing to put across is that in order for this product to work, you need to have active bleeding. Because the way that it works is, if there's no active bleeding, then we're not treating the patient. We're treating ourselves in our endoscopy pictures. You need blood because what the Hemospray does is it helps to almost absorb that moisture and then promote that local platelet aggregation and coagulate and clot formation. So that became very, very clear as we began to, as the data evolved, those sort of forest 2Bs or forest 3s, they don't need intervention. And then I think what Mo has just described to you was actually a really important thing that we did early on is that you're absolutely right that, when we first started, it was perhaps looked at as just rescue therapy. But when you precisely define these three categories, then as the numbers expand in a very, very homogeneous set of patients, then trends begin to appear. So, for example, combination therapy was, not in the context of ongoing bleeding. It was in addition to. So, for rescue therapy, we would wait 5 minutes. If there was still ongoing bleeding, then we put Hemospray. And the same with monotherapy. The primary outcome, hemostasis, was apply the therapy, wait 5 minutes. If it stopped, you're good, pull the scope out. If there's ongoing bleeding, reach for your second or third modality. And I think that as that data then began to expand, it became very obvious that actually in certain lesions, Hemospray had a role as an adjunct in combination therapy, but also I think this is a really exciting time for hemostasis as this data now evolves, and Mo will crunch the numbers with you, where we have historically taught everyone that in order to control peptic ulcer bleeding, we need a combination of therapies. That is the teaching. All societal guidance says you do not pull the endoscope out unless you've applied at least 2 hemostatic modalities. Well, maybe this is time to, just maybe challenge that paradigm, because the data show that in certain patients where you have defined the lesion very clearly, actually monotherapy with this product gives you extremely safe hemostasis rates, and the rebleeding is not far off what we see in some of the other modalities. So yeah, Vivek, there's some really compelling data that's coming out of the data set.
Right. And I think that these are key points. And you mentioned the almost absolute requirement for active bleeding to be present. And so if you see an AVM or an inflammation or a focal area that may have bled and you're treating it with Hemospray, that may or may not be that effective. And in fact, just as a sidebar, this is a different type of a format for conversation and information delivery. But Cook Medical has on repository very nice videos and information available on demand, where you can actually look in the biomechanics of how this product actually controls bleeding and is effective. So very novel, pole position product, first in line of such devices and technologies. So, and now the emerging data set that's coming along with it.